First of all, I express my extreme gratitude to Mr. Manish Jani and his organizing team for inviting me here. And I am really impressed by the efforts and achievement of this Jani group, which they have shown within such a short span. I wish him all success. So my talk is related with the Alzheimer disease in neuropathological perspective. I will present a brief overview at present status and then a brief highlight of the work we are doing and have done at the CDR. So first of all, I would like to tell you this cognition and what is the cognition disorder. The word we use dementia is derived from a Latin word de ave mentis mind. Because nowadays Alzheimer disease you will find so many articles and so many things in journal magazines. The forgetfulness, memory loss, Alzheimer disease. One must be sure that this deterioration in cognitive ability is that impairs the previously successful performance activities of daily living. This is the most important phase of that. Occasional forgetfulness, occasional memory. This occasional forgetfulness, occasional memory loss is not dementia. And cognitive impairments are in memory, attention, judgment, orientation, comprehension, learning, calculation, problem solving functions. Behavioral changes may also be associated. Forgetting recently learned information is one of the most early signs of dementia, but when it is persistent and affecting the daily life. Among the causes of dementia, we see that 57% is from the Alzheimer disease. It is the most common cause of dementia. And then 30% is the vascular, and rest of you can go on this. Infections, Dr. Sharma was asking about the HIV. The infections are also known to produce dementia disorder. So now we come to the Alzheimer disease as such. It was first described by the Alzheimer in 1907. The physician is Alzheimer in a patient, Augustine letter. This is an old lady. It was described, and in 1910, Emil Directive has named the disease after the name of Alzheimer. So disease has been named after the neurophysician, not after the name of patient. So she is the first patient, and he was the first physician to describe it. Then here we move. That is the important thing to learn. That 10 warning signs of Alzheimer's disease. Memory loss. The recent memory loss is the earliest sign. The person may have taken the breakfast, but he has forgotten he has taken it or not. But he may tell you 10 years back in some function what he has eaten. So recent memory loss is there. Difficulty in performing familiar tasks. Problem with the language. He started speaking and suddenly forgets in between what he has been speaking. Disorientation to time and place. One of the earliest signs here happens that an elderly person moves from his house, goes for a morning walk. He was regularly going to park, coming back to home, but gradually he starts forgetting his home, and then it is unable to search where is the home. If some elderly person complains in the family that I feel difficulty to locate my house after returning from the park, this may be the earliest sign of Alzheimer. But sometimes what happens, even a young person can pass from his house because he is something another in his thought. He was thinking something else, he moves ahead, then he thought, oh, I left my house, he come back. So that is not dementia. So persistent forgetting, that is the dementia. Then poor or decreased judgment. Earlier they used to take you ask something, they will reply you and they give you a precise opinion. But there they cannot. Problem with abstract thinking, in that taking absolute judgment and of this bank account maintaining and suggestion. Misplacing the thing that happen very commonly. They may put their wristwatch in their refrigerator. They may put something not at proper place. An occasional mistake may happen with everyone. But if it is happening persistently and it is affecting their daily life, elderly person, then it should be consulted and taken to a neurologist or psychiatrist. Changes in mood or behavior, they go in more in a depressive mood. Changes in personality, loss of initiative. So this type of symptoms, if appears in an elderly person in some family, but if it is happening originally, no problem, but it is persistently affecting his life or life, one should consult a neurologist. Then we come to the Alzheimer disease, the characteristics. It is an age-related disorder. More than 60 years when the age is advancing, then it appears. Dementia, I told you, the symptoms. Then neuropathology, this cluster tract in the brain, particularly in the hippocampus area, which is more involved in the recent memory analysis. In the morning, Chief Guest has told you that monks have to increase their size of the hippocampus. So it is the hippocampal area, which is more involved in cognitive functions and recent. In that, there is neurotic plaque, neurofibrillary tangle, and neurodegeneration. So first factor is the age. If you see that as age advances, this is the incidence of AD, it goes on increasing. I have put the incidence of non-AD also. Just to make it point, though the incidence of AD increases with the age, but at the same time our elderly persons, majority of them are non-demented. So don't think that the person going in aging, he will become demented. So 85 to 89, it may go to 20-25%, but 75-80% elderly person may remain normal. So there should be no fear of aging. Then there is a difference between East and West difference. Occurrence of Alzheimer disease in the Eastern country Asian are less than the Western countries. I will give you just brief some incidences that in India, 65 years is the older age ranging from 1% in rural Mumbai, while in Haryana now we are 2.7 in urban Chennai. While the similar age in the Western countries is 10 to 15%. The lowest reported from anywhere in the world where Alzheimer disease has been statistical. So we have much lower incidence in India with the latest epidemiological studies says. Second, from China and Taiwan also shown a lower risk of Alzheimer disease as compared to Western countries. There is a very interesting study for the Japanese, our Japanese friends are here. The two recent investigations in the rural area of Japan revealed Alzheimer disease is occurred 3.5% of user age 65 or more. The reporters in 1996 among the older Japanese Americans living in Washington and Hawaii revealed the number of Alzheimer disease cases much higher than that estimated in Japan and closely resembled finding for North America Europe. That is a very interesting finding. That means that lifestyle of place where you live that also has some effect. But mind it, have the courage of knowledge. It is impossible to predict who will get Alzheimer disease. No one can predict that he will get Alzheimer disease. It can strike to anyone irrespective of gender, caste, creed, culture or socio-economic status. But one fact which emerges that Asians incidence in Asia is lesser than the African continent. The characteristic of neuropathology, foremost important is a normal brain, age-matched brain. This is the AD brain. If we superimpose, we can appreciate there is a shrinkage of this brain, small size. This is a normal brain. The shrinkage of upper cortical layer. So the brain mass is reduced. Here another comparison, healthy brain in the same age group and it is advanced Alzheimer. So you can see the sulci in the eye has lost and it is a brain mass is reduced. Then the neuronal degeneration is a completely very specific in the area of hippocampus, cholinergic neurons. These are the affected brain areas. I will not go into detail of that. More important is here, there is a decreased level of acetylcholine. Acetylcholine is a neurotransmitter. Neurotransmitters are the specific chemicals present within the neuron and which are released in response to the action potential. and they carry the effects there. So acetylcholine level is reduced, but the cholinergic neuron is lost. Because this is the basis of the at present treatment. Then there are two enzymes, cholinesterase transferase, which is involved in the synthesis of this, and acetylcholinesterase, which is involved in the metabolism of acetylcholine. So cholinergic deficiency has been demonstrated by experimental studies and in human that causes cognitive deficit. So acetylcholine is the key neurotransmitter till today of our knowledge, which regulates learning and memory function as well as the cognitive behavior. And that very neurotransmitter and neurons are lost and degenerated in the Alzheimer's disease. That is the picture of MRI I have taken from the internal medicine of Harrison. 86-year-old normal. This is the hippocampus. You see 77-year-old AD patient, how much hippocampus is shrunk and reduced. You can very well appreciate that hippocampus is the most affected area in the case of Alzheimer's disease. Then the characteristics of Alzheimer's further. This is the Alzheimer's cell. There the plaque you will find. This is the healthy cells. Alzheimer's disease has many fewer nerve cells and synapses than a healthy brain. Plaques, abnormal cluster of protein fragments develop between nerve cells. Then a dying nerve cell contain tangles. Causal neuron cell death, tissue loss in Alzheimer's brain are not certain, but plaques or tangles are the prime suspect. But still it is a big question, they are the cause or consequence. That is the neurotic plaque. This is the plaques. Plaques consists of thick sticky deposit beta amyloid protein mixed with other proteins remnant of neuron, non-nerve cells such as macroglia and other glial cells. Just very brief, I will tell you how this amyloid protein is formed. I think the next speaker, Karin, will deal more on the amyloid protein part. So this is the extra neuronal structure, neurotic plaque. And it contains a spherical deposit of beta amyloid. Beta amyloid protein is derived from the amyloid precursor protein. There is a glycoprotein. A glycoprotein which is present here. Anyway, just I tell you that beta amyloid protein is derived from the amyloid precursor protein, which is a glycoprotein present in the neuron as well as in the non-neuronal cell membrane. This protein is cleaved by secretases enzymes. So this is the beta amyloid protein. This is the N1 terminal. This is the C terminal, 71 amino acid protein. This is the membrane. This is intracellular. This is the neuron. It is outside. It is cleaved by the beta secretase 652 and then by the gamma secretase at 40. 1 to 40 sequence is the normal and it is released, it's soluble. But what happens in Alzheimer's, the 42 sequence is released. So 1 to 40 sequence is insoluble and they aggregate and they make the plaques. You can slide forward. So here, this is an picture form. This is the amyloid protein, spherical. This is the ATP molecule total, and then this is cleaved by the enzyme beta secretase. You see here, alpha secretase cleaves in between and makes a non-amyloid protein, and gamma secretase here. So these enzymes have been a target for the drug development. Because this amyloid protein has been suspected to be the major cause of Alzheimer's disease. So inhibition of this enzyme may block the formation of beta amyloid. 1 to 40 is soluble But when it is 1 to 42, it is insoluble fibrillar and they start clumping together. And after clumping and deposits of the other with the protein, remnant neuron, non-nerve cell, backline, the nerve cells. They make a plaque. So this is the formation how the plaque is formed. So second pathology was the neurofibrillary tangle. The major difference, the plaque was outside the neuron, but this tangle is within the neuron. And in this, there are distorted cytoskeletal structures. So, and it contains hyperphosphated form of a microtubule associated with protein tau. So this is second abnormal protein, but it is present within the neuron and it destroys the neuronal structure, while the amyloid protein and plaque was outside the neuron. So these are the two abnormal proteins which has been very intimately associated with the Alzheimer disease. This is the picture of this just ideal Alzheimer. You can see the left brain loss, mass is reduced, then gradually brain is shrinking, and this is the amyloid deposits. And as the disease advances, more deposits is there and shrinkage of brain is there. 80 patients live an average 8 years, but some people may live 20 years. The course of disease depends part of age, diagnosis, whether a person has other health conditions. Moreover, Alzheimer disease is still not a fatal, but the patients of Alzheimer disease are more prone for the accidents. And it occurs in the elderly persons, so you cannot say it is died of disease or it died of its natural aging. So now after that, why it happens? That's the big question. You name any factor, this happens, and you will find that has been implicated in the disease. But the most important thing which has been clinically proved and had delivered something in the clinical situation. The most important is that acetylcholine. And then other neurotransmitter as supportive, but the most important neurotransmitter is the acetylcholine. Then hormones, insulin and estrogen. Estrogen has been a great hike of after post-menopausal ladies. They say there are cognitive efficiency, HRT, but not still. Large mega trials have been done, and it has not been proved conclusively that estrogen plays the key role. Free radicals, of course, it is any degeneration, any cell degeneration, whether neuronal, non-neuronal, free radicals are there. Abnormal protein, I have just described earlier this, and more, the next lecture you will find more details on that abnormal protein by lecture of Dr. Kelly. Inflammatory process, glucostatin, neuronal apoptosis, industrial calcium, advanced, and all type of drug therapy has been applied on this basis of this. The genetic factor, there are three genes have been implicated in earlier lecture. Yakama, you have seen that he has told about this. This on chromosome 21, this APP gene is located. It was observed that in a Down syndrome, usually Down syndrome patients don't survive much. There is a trisomy on the chromosome 21. If they survive less than 40 years, they show the features of AD. And then there is a single point mutation valid for isoleucine at 717. Then trisinin 1 on chromosome 24 and trisinin 2 on chromosome 22. They encode protein as this protein, and these proteins are involved. They are cytoplasmic interneuronal proteins are involved in the maintaining of the structure of neurons. This was found in the familial onset Alzheimer, 50 Volga German family. They are a very close family, Volga Germans, residing in when they moved to USA in such a state. They was found there at increased level of AB 41 to 42 and multiple point mutation of trisinin genes. But the fact is that there is less than 20%, almost less, genetic based Alzheimer among the total Alzheimer. So total Alzheimer disease is sporadic, not genetic based. In sporadic Alzheimer's, people have been apolipoprotein gene 6 on chromosome 16, 19, which is involved in cholesterol transport. There are 3 alleles, 2, 3, 4. 4 is linked with the onset of aging and AD, sporadic AD. While 4 is while this 2 and 3 has been selected as a protective. But still we cannot say on the basis of this FOPE4 genotype, it will develop Alzheimer. It has been found to be linked with 30 to 40% sporadic Alzheimer. But this is one of the highest occurrence with the genes in sporadic Alzheimer. Then the strategies for the drug therapy of Alzheimer disease, all type of drugs have been tried. Alternative enhancement, that is the mainstay still today. I will tell you later this. That is through by inhibiting the metabolizing enzyme, acetylcholinesterase. If you inhibit the metabolizing enzyme, naturally the level of substance will increase, the acetylcholine will increase. There is a loss of acetylcholine, so approach is to increase the acetylcholine level, and that is achieved by inhibition in its metabolizing enzyme. The anti-inflammatory, all this have been done, but they have been tried and this thing, but not much success. So I will come to the drugs which have been approved and used. The statin, it was the first drug approved by the FDA for treatment of Alzheimer's disease in 1993. It is acetylcholinesterase inhibitor. Here are the dose and frequencies. I will not go into detail of that. Then 1996, donepezil came, rivastigmine in 2000, galantamine 2001. All these are acetylcholinesterase inhibitor. While in 2002 we have a non-acetylcholinesterase inhibitor drug memantine. It is an NMDA receptor blocker, partial and BDNF stimulator. The most common approach at the moment is combination of donepezil with the memantine. Acetylcholinesterase inhibitors, they have shown very promising the therapeutic benefits. They improve the cognitive and behavioral domain and may influence neural function survival. MRI studies in patient indicated acetylcholinesterase inhibitor may increase cerebral blood flow, improve glucose metabolism. There was a study on this functional MRI too. They have shown even the neuron protection against the neuron loss in the hippocampus. But these drugs are full of side effects also. They produce peripheral side effects that include abdominal pain, diarrhea, nausea. They may affect the heart. They may reduce the rate of the heart, and caffeine may cause liver toxicity. So the approach was that there are two abnormal proteins in the Alzheimer's disease. So naturally against the protein we need a vaccine. So with the great effort the vaccine was developed against the beta amyloid, and which was named at 1792 AN. It was very effective in a transgenic mice, but when it was given in clinical trial, it was found relatively safe. One patient died after 2 years. Phase 2 multi-center trial was done, and then there suddenly side effects started appearing, and that was the brain infection type of thing, reaction, autoimmune reaction, and patient, a sufficient number of patients showed death. So trial was stopped, and the result, even it was analyzed that there are no significant, after death of patient, autopsy was performed. And it was observed in the brain that there are fewer amyloid deposits. So one thing was clear, it has reduced the amyloid load. But there are no significant difference between vaccine and placebo on the major test functional. So anyway, it was not a clinical success. So other approaches for anti-amyloid was started. I will go just quickly on that. The active immunization, it is under the progress area development. Then passive immunization approach is also under development. I told you there were the enzyme gamma secretase enzymes which used to cleave the amyloid protein, which was involved in the formation of amyloid protein. Inhibitors were developed, but they were found not to be effective in patients. So recently some few more anti-aggregate approach has been started, and it is under phase 3 is inconclusive. Then the second one is showing some promise. And another thing that recently is lower molecular weight amyloid is being targeted nowadays. The next lecture you will get more information on that. And then with the gamma guard, this is clearance of beta amyloid. Then again the top protein, they are at different development stages. Phase 2 improvement. Then methylene blue, it is also against platelet aggregations. Then there is all these drugs, resveratrol, it is antioxidant, rosicatrol is anti-diabetic. They are various stages of clinical development, and some have shown some promise and some are not. But the major drugs that are still today is cholinergic inhibitors. So this is the present syndrome, the global syndrome of the treatment and the knowledge about the acetylcholinesterase. So now I move forward to highlight brief what we are doing at the CDRI. This is the building of CDRI. It is the palace, Chhatarmanjil Palace. Jaipur is full of a city of palaces, but in Lucknow we do have a palace, but it is not for tourists but for the research. So we are investigating certain roles of isoform, acetylcholinesterase, brain receptors, central renin system in memory functions, in experimental models of memory impairment, and other effort to develop drugs for AD in memory impaired therapeutic potential of synthetic and alpha drugs. So we work on the acetylcholinesterase enzyme because we know this still today the proved therapeutic target is acetylcholinesterase. It exists in two molecular forms, G4 tetramer and monomer. G4 more in the brain and tetramer in the periphery. So we try to do this isoform, high differential role in adding memory or not that. For that thing has been explored, and we had published this paper, and we have studied very different secretion stress, profiling, distribution on this. But I will more concentrate on this memory, this thing to tell you. This is the one model, the passive ardent shock. In which there is a box in which one chamber is the lighter, one chamber is the dark. This is lighter, this is dark. Rodents are, they prefer darkness, so they move to dark. When they move dark, they get a shock. So also on the first day, they move very quickly and we record the time transfer time. Next time, they avoid going to shock. And this is the learning. Scopolamine is a muscarinic antagonist. When we give, it does not move to this, and it moves quickly to the darker side. This is memory deficit. When we give dactyl, I told you the cholinesterase inhibitor and clinically used drug, it improves the memory by showing increase in transfer latency time. So this is experimental setup in which we study the molecular forms. So what we done just in quickly that first we tried in the whole brain to find out with the fast protein liquid chromatography which fraction contains the D4 or which one contains the D1. So we find that fraction 9 that showed the molecule near to 616 and still cholinesterase single molecule is 150. So this is the G4, this is the G1, 13 fraction. So when we subject to learning and this is the control train, you see that this G4 is reduced, fraction is reduced. A reduction in cholinesterase enzyme activity means increased cholinergic activity and more learning. And with the drug, scopolamine, you see the scopolamine with the tetraene is also being decreased. With the scopolamine, it was driven to the control. So G4, changes in G4 is linked with the training and action of tetraene. When we come to this G1, tetraene just did suppress it, but the trained animal did not show change. So that's where we concluded that decreased activity G4 occupies hippocampus, that results of the hippocampus in trained and technical group indicates increased cholinergic activity, enhanced cholinergic activity, special learning memory. We concluded on that basis G4 molecular form may be potential therapeutic target for development of better and more specific anti-drug because it is more linked with the memory function. The paper we published in 2005. Then we studied also the memory impairment, neurodegeneration with the cholinergic thing and streptozotocin models. And this I will show you just in very brief about OKD induced memory impairment model for screening anti-dementia drugs. Here is the Morris water main test, in which we have a pool. We fill with the water, dark color, and there is a hidden platform. We place the rat and it tries to swim to reach on the platform. So by repeated training, it learns and very quickly reaches to the platform. That is the learning. Shown in this picture. On the first session, this is controlled rat, it is taking too much time to reach this platform. Similarly, opioid acid treated rat and donepezil and memantine, these are anticonvulsant drug treated rats. But when we move to the second session, you can see control is showing less zigzag, but here still moving on peripherally and taking more time to reach there. Or similarly, donepezil memantine, they are taking less time and less zigzag as compared to opioid treated rats. Here it is on third session. Daily we give one session of 3 times. On third day, you see the rat has totally learned and reaches one swim to platform. Similarly, while in opioid treated, it is still taking more time and moving here there to reach the. And sometimes they can't reach it. But when we treat with the donepezil and memantine, they are reaching the platform. That shows these drugs are very effective against this memory impairment, and this model we suggested to be used as experimental model for screening of anti-dementia drugs. Then we have worked recently on the brain and insulin, because there are specific brain insulin receptors in the brain. We found that their brain insulin might have role in regulation memory function. This is the signaling pathway, iris AKT pathway, CA3, these are hippocampal associated. Renin angiotensin, they may central. Renin angiotensin is more involved in the cardiovascular, but in the brain there is a system, and that may be influence central blood flow and memory function. Then, as in central drugs cure, naturally we want a drug for the patients. So on that basis, we have tried to formulate the evaluation of memory enhancer among the herbal origins. We have inverters, elixirite, and then gugulipid, and effect of quercetin, and the curcumin. We have also seen the curcumin here also, and silibinin. These are all the antioxidants. The question was raised: the antioxidant can play a role by protection or neurodegeneration. We have obtained the US patent and European patent for the use of gugulipid as cognitive enhancer. Synthetic compounds, we are also in that interested, and we have recently published in JAMA, and for that we have taken European and US patent as a potent acetylcholinase stress inhibitor. I will just give you a brief highlight of the gugulipid. Gugulipid is a gum gugulu. It is called Commiphora vegetae. Gum-resin acid Commiphora vegetae has been used in Ayurvedic medicine for more than 2000 years to treat a variety of ailments like obesity, lipid disorder, rheumatoid arthritis. Gugul, a child extract of resin plant of Commiphora vegetae developed CDRI as hypertonic drug, and torrent introduced in the market as a gugulipid. It was used in the patient, it is being used in the patient, and major constituent gugulipid is gugulesterone. And then you see the model I told you, passive avoidance. In that, like donepezil, compared to the standard drug, gugulipid in a dose-given manner has increased this scopolamine against memory deficit. So that shows the potential as anti-dementia drug. We further studied for the normal, this is Morris water, this is the normal control rate. Here you can see they may show a little early learning. A chronic administration of gugulipid. Then we come to the neurodegenerative based dementia model streptozotocin, in which we give the streptozotocin bilaterally in the brain, and after 14 days we study the memory function and they show memory deficit. If during that period we give the gugulipid 50 mg per kg, in preventive mode or even after this memory deficit, buccal lipids showed a very prominent and significant prevention as well as improvement. That you can appreciate from here that this is the normal learning in the swimming. If you remember the swimming test, there is a gradual decrease in latency time indicates successful learning. And streptozotocin, they don't show decrease, that is memory deficit. This is the standard development which shows a significant decrease in the streptozotocin. That is the paradigm of to study and say that this drug is potential anti-dementia. So here when we give glucolipid, prior to that it shows a decrease, and after the establishment of deficit we give, it shows the decrease. So glucolipid was found to be effective as preventive as well as post-symptomatic. Because in the clinical situation, patient is come with the symptoms, so that should be effective when symptom is already there. So find out some mechanistic aspect. We studied the acetylcholinesterase activity, and we found the glucolipid in that rats. On chronic administration, preventive mode decrease the acetylcholinesterase activity, but not in the short term administration. So chronic administration of glucolipid may decrease acetylcholinesterase activity and increase cholinergic activity. Then it has decreased, it increased the GSS level, indicating an antioxidant. This antioxidant activity, streptozotocin decreases GSH, and while glucolipid increases it. Then another marker of oxidative stress, NDA, was significantly decreased by the glucolipid treatment pre or post. So on that basis that glucolipid acts as a potential anti-dementia drug, this activity can be attributed to antioxidant activity as well as enhancement of cholinergic influence. That we had published paper 2007 and we obtained the patent for this because this drug is being used in the patient as to decrease the lipid levels. So with that we come to the final and summary. What happens? There is a cholinergic neuron loss in hippocampus. We have two abnormal proteins. Whether they are causing that or they are the sequence, we don't know, but they are most implementary factors. Causes may be stress, inflammation, hormone, free radical, metals, genetic, or maybe we still do not know which is the real cause. So what we need in a patient, cholinergic neuron loss, we know they cause a symptom of dementia. So dementia is improved by the cholinergic drugs, but we need a neuroprotectant here to modify the disease progression. So what we need to drug which can act here as well as can act here. So in that way, glucolipid is one of our effort which has shown antioxidant activity can stop the progress of the neuron degeneration, and cholinergic activity may help in improvement of symptoms. So we hope we may get more effective drug of maybe drugs like that which have both action on the cholinergic activity as well as the neuroprotection. And that is our the future hope. That if we get this, so this black and white gloomy lady may be converted to a smiling, colorful lady. I acknowledge my team persons, Dr. Madhu Dixit, Rajesh Shukla, they are senior scientists of CTRI, and this is my PhD students who completed the work on the acetylcholinesterase, Gunjan Saxena worked on the neurodegeneration cholinergic mechanism, Rahul Agarwal worked on the insulin receptor. These three are still working, Santosh, Tuna, Renin, Injecting, Kamat, Propedic acid, we are on the gland cell neurodegeneration. This is the river Gomti, which this palace is situated, our institute. So with that, I thank you all.